which was actually led by His Excellency, Chief Executive Officer of the National Guard for Health Affairs, Dr. Bandar Ganawi. And what we meant to do today is just to take you in a brief round and very important topics that has to do with the theme of the or slogan of the Patient Safety Day this year, which is the safety of healthcare worker is very vital and important for the patient safety as a whole. With that, I would like to introduce my colleague, Dr. Hassan Al-Marhabi, who is the director of the Quality and Patient Safety in Jeddah, who will be the co-chair in this session. And the presenter for the very important topic, which is the just culture, will be Dr. Yasser Gazzaz, who's a colleague and a friend. He is a pediatric intensive care consultant in the National Guard, and actually, I believe he joined us 2015, coming from University of McGill and University of Toronto. And he's currently the assistant director of the Quality and Patient Safety, and he's taking care of a great work in the cash side. With that, I would love to welcome Dr. Yasser Gazzaz, and thank you very much for being with us. Yasser.
So good afternoon, everyone, and thank you for joining us today for our workshop about patient safety. Before I start, I would like to thank the team who organized this workshop and made it possible for us to meet all of you today. And without further delay, I'm going to talk about just culture. So I'm just going to take a second of your time. If you don't mind, I would like you to log into this webpage. Basically, this is going to be a way for me to communicate with you and get some of your feedback and have some interactivity of this session. So this is the website you're going to get. For now, you're not going to see anything, but in the next few slides, you're going to be able to see some interactivity. I'm going to guide you through that. So I'm actually going to start with what I want you to come out of the first session, and then I'm going to go through it. So my take-home message for us today is that as healthcare workers, we should be able to admit our mistakes freely to improve the system. We are, in addition to the organization, we are both accountable for the behaviors and action that occurs. Behaviors that we do matters to us more than the final outcome that the patients have. And at the end, the slogan of the World Patient Safety Day is the safe health workers is going to lead to safe patients. So the concept of safety and no harm is not new. So it's since the 1800s to us. And this Florence Nightingale, and basically she's the mother of modern nursing, who said that the first requirement in hospital is to do no harm to patients. Just to say, Florence Nightingale is the person who introduced hand hygiene in the World War, and that actually her actions for introducing hand hygiene result in drastic improvement in mortality. Although this concept has been, as I mentioned, since the 1800s, have we reached the period of no harm? Unfortunately, so far not yet. This is a US data that shows 1 in 10 patients will be harmed in the hospital. 1 of 20 patients will have hospital-acquired infection when they're in the hospital, and 4 out of 10 patients will be harmed in primary and healthcare outpatient settings. So why is this we haven't controlled yet? Because we really, with the advance in modern technology, yes, we improved our medicine, but it came with a complex. This is, for example, an area where I work at. So there's several monitors, several machines, advanced technology, several equipment that makes caring of patients more complex than before and makes error happens. So as people, as humans, we're gonna make errors. Errors might lead to accidents. And in healthcare, these errors, if it leads to accidents, is gonna result in morbidity and mortality. So the stakes is high for us. But the issue is, what should we do when errors occur? This is what we are looking for. So errors are gonna occur, but how are we gonna deal with it? So we learn from our errors. So we investigate, we get all the data that we need from the errors, we analyze, we switch this data into information, something that we understand, And basically, in our understanding inclusion, we need to act. So what sort of actions we take when error takes? So historically, there's been two sorts of approaches. The initial one, error occurred, so we're going to focus, the error is going to be focused on the individual. So the individual is the bad apple, is going to be blamed. Why is that? Because we are, as healthcare providers, we are different than other workers. The stakes are high, we receive high intensity education, so the theory behind this, we should always not forget, we should always have high attention because the stakes are very high. So this is one of the theories to deal with errors. Another theory is actually we are human beings. Yes, we are educated. Yes, we are embedded in the system. However, error is inevitable. So, and if errors occur, why is that? The errors occur because historically, when you look back in time through the levels of the system, you're going to find that it goes to the system. And error is inevitable. So the system error is what we call a no-blame culture. So between the two theories, so have the person or the bad apple, which is the punitive culture. As we said, stakes are high, it's human life. Human failure is not forgiven, and the severity of our outcome is going to be lead. And we need to have disciplinary actions. In the other side, there's no blame cultures. It's okay to do errors, it's again to the system. So we need to find the system that will fix it. So that's how things moved. But what we really need is the balance between two. We need to find the balance between this punitive and no blame culture. And that balance is called just culture. So when we look at how we support our system by learning from our errors and actions, so we blame-free versus punitive cultures both have not led to improvement in the supportive safety system. But when we go into the accountability just culture, and that's applied through the regulators, institutions, leadership, managers, and healthcare providers, that we can improve our system. So what is culture? I would like you to log into my webpage. I'm going to give you like 30 seconds. Tell me in one word, what do we mean by culture? So I hope everyone in the audience is able to log in this web page, and that's what you're going to see. I just want you to answer in the upper word, which says word cloud. What do we mean by culture? So just in a word or few words, what do we mean by culture? So I'm going to move on, and hopefully a few of you have replied to that. So it's a community, it's a place we practice. So those are actually two good words. So yes, the culture is actually our beliefs, it's our behaviors and values that drives our action. It's the compass that leads us to action and to do work. So when we do something and we are told this is right, we're going to repeat this action. When we do something and we're told it's wrong, we don't repeat it. And it's basically culture is what people do when no one is looking. So that is culture. So just culture definition is an atmosphere of trust in which people are encouraged for providing essential safety-related information. So we report safety issues. We know that we are open to report safety issues. And we trust that we will not, as individuals, be accountable for system failures. So we understand there's two things. There's us and there's the system. And when an error occurred because of the system, we're not going to be accountable. However, there is a very clear line that has been drawn between acceptable and unacceptable behaviors. So yes, we are all accountable, and that's the fundamental attribute of just culture. We need to balance the accountability between systems and human behavior. So as healthcare institutions are accountable for the system they design, us as healthcare workers, as staff are accountable for the quality and the behaviors and the choices that we make. So this is just culture model. We have systems, we have behavioral choices, and that's going to lead to the outcome. The outcome can be desired outcome, or unfortunately sometimes it's undesired outcome. So I want to take another minute from your time to log in the poll again and see. And this is the story I'm going to give you 4 options. But it's a story of a surgeon who's at a conference and sees a new piece of equipment. So it's a less invasive equipment that they can use in the surgery, and they say the outcome is really great. It's going to shorten the OR time and decrease length of stay. That surgeon goes back to the hospital. There's someone who says, you know what, you can use it for the next surgery. However, there's an OR policy says new equipment have to be approved by the hospital first. The surgeons find the equipment. He really believes what was told, that it results in less invasive and shortened OR time and length of stay. He does the surgery with this equipment, and actually the patient does really well. So the patient is discharged home after 1 day in contrast to the usual 5 days. So this looked really, really well. So now we found out that the surgeon used this new equipment. What should be done? If you log into the web page, you're going to find 4 options. We appreciate that surgeon because they introduced something new to the institution that's going to work really well. Or it's okay, we don't need to take any action. Or we encourage a different behavior or coach them, or have actually discipline or punish that person for using this equipment. Again, I'm going to give you around 30 seconds, and on the right side, that's how it should look to you. So you should choose one of those 4 options for the surgeon who used the new equipment, and the result was really well. The only thing that they did not follow the hospital policy. So I think we'll move now. We'll see. So we're going to encourage different behavior. We're going to appreciate them. So most commonly, it's encourage different behavior. Let's look at this story again, but this time, so the same story. They found the new equipment. They went back to the hospital. They find the equipment. They were aware about the policy. However, they do the surgery, and unfortunately, the surgeon was not aware about this equipment really well. That accidentally punctured the patient's valve. So the course is really complicated with shock and instability, and result in ICU admission and really prolonged length of stay. So now, what should we do? So the scenario now, the outcome is different. The physician did the surgery with the same equipment, but the patient really didn't do well. The patient went to the ICU, had shock, so the patient was at risk. Again, the same thing. I would appreciate if you join us and answer. So for a few more seconds. So same scenario, exactly. The only difference is in the outcome. So patient did really well. Now the patient did not do well, and he basically had a complication or a morbidity. So now, as you see, there was a shift between initially there was appreciation. We moved actually to encourage different behavior, and actually there's more votes on disciplinary action or punishment. The focus of just culture actually is not to look into outcomes. So the outcome does not dictate how we look into the incidents, how we look into errors. So it's not really if we are lucky and the patient had a good outcome, or if we did everything well and unfortunately the patient had a complication. So the central concept actually of just culture is not what we did just now. It's not, we move away, we shift away from the outcome that the patient had, and actually we focus on the behavioral choices. And those are the behaviors that we look at. So we don't look at outcomes, we look at the behaviors that resulted in this outcome. So either the behavior can be a human error. So basically, it's a mistake that we did not intend to do. It's a slip or lapse that caused an outcome that was not intended to be. So this is a human error. We do human errors. Or at-risk behavior, when basically we are competent professionals develop unhealthy norms. So the behavioral choices, they take shortcuts. So we do things we think that the risk by taking this shortcut is actually doesn't exist or can be justified. So the behavior that I did is going to give me a very minimal risk, or even the risk is very justified. So this is at-risk behavior. Reckless behavior is consciously disregarding the substantial and unjustifiable risk. So we know there is a risk, but we don't care. So this is reckless behavior. A real-life example before going to hospital example, speeding. So we go above the speed limit. So human error. I'm just driving, coming back from work. I'm preoccupied with work, and suddenly I notice that my car gives me an alarm. I exceeded the speed limit. So here I was not focusing, and I exceeded the speed limit. So that's a human error. At-risk behavior, I'm late for work. I know that's not going to look good when I reach there. So basically, I'm going to still focus on the road. I know that I'm speeding, but I think by speeding, I'm going to be very careful, and the chance of me having an accident is very minimal. So I took the risk just to arrive early at work. So that's at-risk behavior. Reckless behavior, I'm just speeding. I want to speed throughout the streets. So it's a reckless driving. I'm switching between lanes. I'm driving and texting. Basically, I know that there's a risk of having an accident, but I don't care. So this is a reckless behavior. So those are the three types of behaviors that we need to assess to know the actions that we're going to take. So how do we analyze that? So a human error, did that person chose the behavior to do? Not really. He just slipped. And because he did not choose, he actually did not think about the risk. But error occurred, harm occurred, what to do to those people? So we counsel them. We need to counsel them to the effect that happened. As well, no one likes to do errors. So we need to counsel them that this error happens, human error happens, and then we need to look into how to prevent it in the future. So we look into the system itself. At-risk behavior, that person chose the behavior, but he thought there was no risk or justifiable risk. So what do? We coach them. So we show them why this behavior should not be done, why the policy and procedure that they shortcut exist. An example of that, we need to give blood transfusion. We know that there is double checking, but I'm going to check it by my own. I'm 100% for me. Let's sure that this is the right blood product I should give the patient, and I was wrong. We should do 2 checks. So I thought that the risk is very minimal. I was not right. So this is coaching. Reckless behavior, I chose the behavior. I know that there is risk, but I still did it. For example, there is a medication error that happened to a patient. I hide it, and the patient deteriorates. So I didn't tell the other healthcare provider taking care of that patient. And that's a reckless behavior, and that's required disciplinary actions. So then the goals of just culture. So we are designing a safe system that will reduce the opportunity for human errors. So we reduce those slips of human errors and catch this error before they reach the patient. So those are the near misses. Those are the errors that didn't cause harm. And we focus on less focus on events and outcomes. What we care for as I said, the risk is the behavioral choices. That's what we care about. And by enriching this culture, we encourage reporting of the events and near misses to identify and fix those problems proactively before an actual harm really occurs. So how to bring this just culture to life? So first of all, we need leadership commitment. For example, we have a leadership commitment. We need the guidelines, the policies and procedures, the guidelines that's going to tell us which case is which is at risk, which is reckless behavior, and what to do when those errors occur. We need to have a good citizenship. Us as healthcare workers, we need to feel belong. We need to feel safe. We need to know that this is part of our job, to be transparent, to be part of this whole family, to report errors that we do. And at the end, we need to educate the whole system on the safety concept, on just culture concepts, to make it clear for everyone what is the difference between a system error, between accountability. Accountability, is it the system that's accountable, or us as healthcare workers are accountable? But let's not forget, when medical errors occur, it's devastating for us, for healthcare workers. None of us go to the work with intention to cause errors and harm for the patients. And that this harm goes through investigations. We are part of root cause analysis when we do errors. There's emotional and anxiety, depression, and sometimes this might go through suicide. So there is a formal support system that should be there. And that formal system, my colleague Dr. Kathir is going to talk about. Dr. Amar as well is going to talk about what to do in a stressful situation. So besides just culture, there should be a system where we really provide support to the people who commit, unfortunately, errors. And at the end, I would like to thank you all for attending this workshop. And if you had any further questions in relation to just culture, please don't hesitate to communicate with me. Thank you.
Thank you so much, Dr. Yasser. Hello, Dr. Yasser?
Yes, I'm with you.
Okay. Thank you so much, Dr. Yasser, for this really nice presentation, which is, even it changed my mind when you have like one surgeon, he did the surgery, one with the complication and one with no complication. So now we will answer the questions from the audience. So I will start with my questions, Dr. Yasser. So if you have like repeated human error, how we can differentiate between like if repeated human error, this is at-risk behavior, or like this is reckless behavior, or how we can deal with the repeated harms.
Thank you, Dr. Hassan. So actually, Just Culture even addresses that point, and thank you for, I did not bring it up in my presentation. However, Just Culture addresses repetitive behavior. So if there is a person who does repetitive at-risk behaviors or several human errors, both of those warrant a different response. So it's not only gonna be always counseling and coaching for those issues, it moves actually, it shifts their activity to disciplinary actions. And that's when the whole system looks into the repetitive behavior. So the trends, or to find that errors occur from the same person, triggers us to look into things differently. So we don't look at the single event, we look into other events as well.
Okay, thank you, Dr. Yasser. So we'll go down, okay. Okay.
Dr. Hassan, can I just, yes. Okay, that's it. Dr. Ali. Dr. Ali, you have, thank you, Dr. Hassan, and thank you, Dr. Yasser. Thanks very much for the great lecture. And I think we have Dr. Ali Khatami just joined us. So off you go, Dr. Ali. Yes.
So sorry. Technology is beautiful when it works, but when it fails, it fails. I had technical issues, and I really apologize for this delay. I'm so honored and really privileged to be with this elite group. We have here the great presentation from Dr. Yasser. Thank you so much. That was really wonderful. And what I wanted to comment on your presentation, Dr. Yasser, is that we are, as healthcare providers, we don't go to job to kill people or to make mistakes or to do intentional errors. So if you look at our experience in National Guard Health Affairs, we process more than 35,000 SRS, which is incident reporting system for those who are not, who don't belong to National Guard. And majority of them are errors, system related. People are maybe tired, burned out at the end of the day, but they are not reckless behavior. So this is very, very important that we create this culture to hear these errors, to report them in a very safe and fair way. And I have heard from the clinical areas. I'm a neurologist, I'm still practicing, and I come to emergency and I go to the clinics, and I hear people when they mention SRS, they think that this is a complaint against colleague, and that's not, at least in our culture or the way we in quality and patient safety look at it. We look at it as a very important tool to get into the system, have a corrective actions, and work on it. It's not a complaint, it's basically just bringing these issues to the surface so we can actually work on them together in a very collaborative, non-punitive, non-blame, no shame things. Very, very rare. Since I joined the quality and patient safety, it's very, very rare to see these reckless behavior because we are trained, we are very well selected, we're committed, we're human. We don't harm patients by intentions. So it's a very, very important that healthcare system adapt this just culture. And I'm very happy the way you presented, Dr. Yasser, is so beautiful. The mic is yours.
Thank you very much, Dr. Ali Khatami. And Dr. Ali Khatami, technical issue shows the complexity of our system. And that was not, that was a system issue. It was not a human error. So thank you, Dr. Ali, for able to join me today for this presentation. If there's any questions, I'll take them. Otherwise, I think we can move to Dr. Mohamed Al-Iban presentation.
So I think we can move to the second presentation. I think the chairperson.
Okay. Okay. So first of all, I would like to thank Dr. Al-Khatami and the Quality and Patient Safety Program, our colleague, all of our wonderful colleagues in that very important program. And my name is Mash Shumrani. I'm the Executive Director of Infection Prevention and Control. We coordinate this topic, me and my colleague, Dr. Mufarrah Al-Kathiri. Dr. Mufarrah Al-Kathiri is the Director of Quality and Patient Safety Department, Central Region, National Guard Hospital, Riyadh. The topic is very important. It's about just culture and accountability during COVID-19 pandemic. We know all of us that COVID-19 pandemic put a huge pressure on organization to maintain their staff, safety and also patient safety, and from different angles. One of them, and very important, sometimes we don't look at it, it's how to build the culture of safety where everything inside the hospital is safe, so we'll not have any infection among staff, we don't have any infections among patients. Also, very important part, which is to maintain providing essential services, those with cancer and those with emergency thing and dialysis cases, they have to be maintained and service need to be continued. So this is a huge pressure on organization, and they're accounted to maintain that culture of safety. I don't want to go further, but I will give the mic to my colleague, Dr. Mohamed Al-Iban, who will present this very important topic. He is the General Director of Corporate Planning and Regulatory Affairs, and he is also emergency medicine consultant and assistant professor in King Saud bin Abdulaziz University of Health Sciences. Dr. Mohamed Al-Iban.
Thank you, Dr. Majid, for the introduction. I would like to thank Dr. Ali and Quality and Patient Safety for the invite for this wonderful event. That it's focused on the patient and the health worker safety as a way to produce or improve our quality to patient care. Also, I would like to thank Dr. Yasser to lay the ground for the presentation. You make it very easy. Thank you so much. So, simple outline of our presentation will have presenting a case study about our MNGHA response during COVID. And we highlight the system strength in form of keeping patients and health workers safe. So the outline will be simple introduction about the just culture and how we sustain safety culture during the crisis. And we'll go over some of the MNGHA initiative during COVID. So, healthcare safety culture has a turning point after the landmark Institute of Medicine report in 1999 that it's highlighted the issue and differentiate the error from the at-risk behavior and reckless behavior to error as a human. So that report triggered an international response. Multiple governments, multiple NGOs has focused their fund research on system enhancement, support learning from other industry with strong culture towards safety like aviation. Reaching to the end points of simple definition of just culture that's balanced between punitive, non-punitive institutional response toward error, while maintaining the accountability toward reckless neglect behaviors. What was unique about COVID crisis, it's definitely a unique time and experience at all levels and different sectors, not only confined to healthcare. It has characteristics of highly uncertainty, rapidly evolving unexpected scenarios and events, which represent a huge stress on healthcare worker and healthcare systems, which is represent a huge test to our safety cultures, where during stress you expect more blaming, more finger pointing at each mistake due to stress. What differs COVID-19 crisis than other usual or known crisis, explosion, God forbid, earthquake, that's the during crisis stage lasts much longer than the usual disaster that usually lasts for a few days, then it's regain and recovers. And have also an intensive intervention at all levels, from international player, WHO, national ministries, Ministry of Education, Ministry of Health, Ministry of Interior, Ministry of Economy, Ministry of Labor, and with the local stakeholder within your institute. To respond well to such crisis, you need an organization that had the flexibility, the on-the-spot decision-making, and super high coordination and workforce engagement to support your action with continuous feedback cycle. Why I believe that it's really a huge initiative that was done at the Ministry of National Guard Health Affairs and the Ministry of Health aspects to maintain safety culture during the crisis is really the transparency. The transparency, I believe, is the most critical factor to accountability, to gain accountability and public trust. We remember and we see it today every day at a national level. We have sharing reliable information from reliable sources to the public that enhance our awareness about the situations and gain our trust and help us ensure the adherence of the public or the employee to all precautionary measures that it applied. In our system, we have a similar way of reporting that through the Executive Director of Medical Services, the leadership, that every week on Thursday, we have weekly report about the total cases diagnosed at King Abdulaziz Medical Cities, total recovery, total death. In addition to that, you can find some additional resources to share information about whatever updating the guidelines, what kind of frequent asked question from the frontliner, and we respond to that through the distributions. On top of that, you should have a top-notch communications way or communication plan to relay your leadership plans, your leadership initiatives through multiple platforms. So we have a top to mid leadership regular meeting, daily huddle in the mid of the day, each day during COVID crisis. Utilizing the MJHA distribution, email, SMS to employee and patients, social media, especially Twitter, to deliver informations, policy, and related messages that we want to deliver. In addition to dedicated hotline for both employees and patients to answer any concerns, any questions, to establish the trust our healthcare world. To have an insight about what's constituted of the regular daily huddle, usually it's happened midday. So the middle frontliner staff usually can relay their concern, their issues to their directors who were participate through this daily huddle. So usually 4 main items are discussed every day: the bed capacity, the logistic supply status, mainly the PPE, and ensuring that healthcare workers have enough supply of PPE, and other employee concerns that emerge during the event. As we mentioned, that we have very rapidly evolving crisis with multiple issues that you might not consider in the planning, like the changing in curfew as an example. In addition to that, if we have any patient-related concern from patients' relations, from any department that reports some concern of the patients regarding the best example, I would say, the visitation policy, that they have some concerns communicating with the patient family to relay their patient status. Also, the focus on employee safety, as we mentioned, we have a rapid response team to provide all required PPE supplies, led by the logistic team, infection control team, and nursing team, with mass training on infection control, precautions, safe practices, not forgetting the mental wellness of our employee, that it will be described, inshallah, by Dr. Omar later in the day. That it's not only the physical safety for our employee, but also taking extra step toward mental wellness programs. In addition to that, strict policy toward employee safety precautions, whether universal masking, social distancing, closure of sharing common area, prevent visitation policy. So this is the main themes that what happened in as a response from MNJHA toward the COVID crisis to maintain healthcare worker safety. So furthermore, I will go over the multiple initiatives that happened during COVID in multiple aspects: in awareness and education, in terms of policy and procedures, in terms of safe workplace environment, in terms of PPE availability and accessibility. Also, we'll talk about the staff and patient access to care and isolation surge capacity, and the leverage of technology and telemedicine to support our healthcare worker and support our patients. A few examples that you can see the pictures, that multiple webinar was done directed toward the training, the education about the utilization of PPE precautions, education about COVID-19 as a disease, what we expect. Also, multiple simulation courses were initiated to ensure proper procedures that will be actioned during the real time. We move even further outside the hospital to military school, to our university, our medical research, to conduct some multiple visits for education purposes. In terms of policy and procedure, with support of our infection control team, we developed multiple interim guidelines based on the updated international and national guidelines. So multiple policy about the procedure, case definitions, some policy about PPE usage, and other policy about the workflow charts for high-risk units. So the frontliner, they don't have to have multiple question, multiple concern, all described in the simple workflow to facilitate their action. In addition to the other guidelines that implemented, I believe, in all national level, closure of recreational center, opening eating area and praying areas. Also, our system has developed, our support from IT developed working from distance VPN to our employee that can do their work from home, decreasing their risk for infection, minimizing exposure to the disease. For the safe workplace environment, we have mandatory universal masking on all facilities since the day one, mandatory social distancing, definitely separate COVID-19 units with mandatory full PPE for all staff within that unit. Also, for the environmental disinfecting, we're utilizing top-notch technology, ultraviolet disinfectant technology, providing HEPA filter to all rooms, providing that's make the healthcare worker more assured about his safety, that the system is working toward keeping his safety as priority to serve the patients. One of the emerging issues that happened during COVID, that's multiple new products have emerged through the market during the restriction on the import and the export. So that's triggered a team for evaluation and new and fast evaluation for the safety and applicability to our standards, from PPE standards that N95 is really securing the patients, creating enough seals to the healthcare worker to ensure they're working in safe environment. Also, guidance on extended use, reuse of PPE with strategic storage of the essential PPE, so we cannot have loss of storage or get out of stock for any PPE, God forbid, at any moment. Regarding staff and patient access to care, multiple initiative has been done. We have utilized, with the help of the university, the simulation center as the tracing and swapping unit for COVID-19 for stable patients. We established multiple fever clinic in our primary healthcare centers. We developed with our emergency team public outreach program with hotline that answer any concern to the public regarding COVID-19. Also, we have initiated designated or arranged for designated COVID-19 isolation area and hotels to ensure the safety of infected staff patients that have no enough setting or appropriate setting within their home with 24-hour medical coverage. Moving to isolation surge capacity, we can see from the earlier time before the surge happened, we developed an emergency plan for our infectious disease. It's clarified according to the phases, the requirement, the moving from normal ICU to ICU for COVID with negative pressure isolation areas, similar to ARI, with continuous daily feedback about the situation and whether to escalate or de-escalate accordingly. This is the picture of the daily report that's happened at the director levels that shows our capacity from confirmed COVID cases, whether ICU and ward, total cases of suspected, and our vacant or surge capacity that's available to accommodate more patients. In regard to telemedicine, we leverage the telemedicine with our support in IT. We have multiple initiatives that were done to ensure equity and improve access to non-COVID patients. So multiple of our patients have significant fear to attend to the hospital during the COVID news. So our team supported with the virtual clinic application that's enabled patients to have an interaction with their physician during their clinic time. Also an application utilizing the normal applications, MNJHA Care, to request the supply for mainly pharmaceutical, which we have really difficult for the patient that they don't have a clear access to care with no method to reach for their medication. In addition to that, we established multiple solution targeting screening for our employees. So we have a regular automated symptom checker that were sent to all National Guard employee that's having simple screening tool that giving their direction about according to their scoring, whether to report to the work or to report to the employee health clinic or isolate themselves at work, at home. In addition to multiple dashboards to utilize the data to monitor employee infection rate and act upon any unusual trend in some units that facilitate to trigger more educations, more intervention to support the healthcare worker safety. In addition to our overall database and monitor, we have smart tracker systems that link the care of patients through the whole journey, whether from home, the family medicine will conduct a daily check on our patients, moving to inpatients, moving to quarantine facilities. This system has facilitate the care of the patients throughout the journey, that we don't miss any patient, whether they're at home or quarantine or inpatients. In addition to that, we have clearly monitored our lab testing capacity and positivity rate monitoring during the event, and to have more further planning according to that. This is the chart about laboratory capacity regarding testing capacity for COVID. The usual turnaround time, maximally it was 24 hours. At the end, I would say the employee well-being and safety is the cornerstone for better patient care and safety. Transparency and effective open non-punitive communication channel is the key to success in promoting just cultures at your organization. And remember, eventually, just culture does not contradict or violate individual responsibility toward their action. With that, I will conclude my presentation. Thank you for listening.
Thank you, Dr. Mohammed. Thank you very much for your presentation. And as you can see, that safety culture really need to be built, and this is the organization. The organization need to have a person around for testing in the lab. They should have enough PPEs for the staff and frontliners to be safe all the time, and also to have they should have built an access for patients to continue medical services. And this will alhamdulillah with efforts of everybody, it's been achieved in different levels. Then we'll come after that how to maintain a just culture, how to maintain this, how to make it sustainable. Then the next step means that we need to put some policy and procedure to define accountability and also to cancel those who violate, and maybe to be more toward even violation some sort of policies to manage and maintain that beautifully built safety culture. I would just ask maybe my colleague Dr. Farah Kathir if you have any further thing to say, and also open any questions.
Thank you very much, Dr. Majid and Dr. Muhannad, for this wonderful presentation. Maybe there's some question here. Maybe I can read it if any one of you, Dr. Muhannad or Dr. Majid, answer it. A certain healthcare worker refused to take care of COVID positive patient because there was no proper PPE to use. Will organization have a right to reprimand her? Or like if the physician refused to go near the COVID positive patient to intubate because there was no available proper PPE to use, and the patient dies because of delayed intervention, will this physician have accountability for this action?
Okay. You're muted, Muhammad. You're muted.
Yeah, actually, this is one of the main points that were said at the first point from our leadership, that we cannot endanger our healthcare worker safety at all. So the priority at all time is the healthcare worker safety. If no proper PPE, that's the problem of the institute, and they have to provide proper solutions, provide alternatives about what kind of precaution that we can use, but definitely that we cannot allow or endanger our healthcare work safety at any time.
If you allow me just to comment on that also. Whenever we have something like this, and it happens, it's not something that we didn't see. We see it, and we saw it a lot, especially in the when things started, in January and February, we start seeing patients at first time. And we need to look at it in more, if you like, different from different angles. We need to know what does mean, what does mean here, non-proper PPE. What does that mean? Non-proper PPE. Some people, they think that we have to have a jumpsuit. We should have spacesuit to see it, maybe with an armor, shiny armor, and they have this kind of, So we need to sit and understand, in a way or another, what they want, and organizations, they don't have like a sword or an axe and going around. Okay, you didn't want to see a patient and we'll hit you on your head. No, we don't do that. So we need to go and sit, and I did that a lot actually. I sat with different people. Some of services will actually want to close. They don't want to continue services, and we understand the concern. We educate them. We sat with them. Some of them, they even they came ready with reviewing literatures about what kind of PPE they want. And with time, we overcome that, and they manage without any kind of, well, they said very nice word, prompt it or reprime it, without anything. So they just go and they continue their service. So we need to assess, we need to understand, we need to counsel, we need to train, we need to show people evidence and communicate in a nice way. And with that, we can overcome most of these kind of concerns easily. Thank you. Is there any more questions, Dr. Farah? You're muted.
If we apply just culture here as an algorithm, Dr. Yasser, what do you think?
So as Dr. Maj Shamrani actually elaborated, there is we need more information to understand the situation really. What do we mean by appropriate PPE? What happened really? I think there's lots of missing information here before I can say how we can apply just culture and just give you an answer for that.
Okay, I see that.
So let's say, Dr. Yasser, if we sat with the people, we explain all the processes, we educate them about availability or what kind of safe PPE available in the hospitals, and that we are sure from scientific and evidence point of view, it will protect. And this is not only the standard, it's beyond the standard when it comes to applying a safety measures. And they're still refusing to see measures. What will we do then?
Okay, thank you very much. Anyone have further comment from presenters here? Okay, so from now I'll conclude, and thank you all, Dr. Majid and Dr. Muhannad and Dr. Yasser. Who's the next now?
Bismillah ar-Rahman ar-Rahim. Assalamu alaikum jami'an. Good afternoon, everyone. This is Dr. Shahar, Director of Quality Management Department in Dammam, the moderator of this session with my colleague, Dr. Ammar Al-Hassani, Associate Executive Medical Services in Medina Al-Munawwara. First of all, thank you for having and sharing such important workshop in the Patient Safety Day, and with the important topic about second victim. Now, as you know, inside the kingdom, outside the kingdom, the organization starts implementing the second victim program for healthcare providers who are emotionally impacted or traumatized by the patient-related event. And the hospital start to implement this program, implement the RISE team. More elaboration will be from Dr. Al-Kathiri regarding the RISE team and how is the healthcare provider in coping with their emotional challenges. And as far as I know, now this has been introduced to most of the accrediting body. GCI start in the last edition to add it in their standard, SQE 8.2. Sibahi, they will release the new edition in this year, and it will include some standard related to the second victim. Our speaker today is Dr. Al-Kathiri. Dr. Mufarrih Al-Kathiri is general internist, and he has a fellowship in quality and patient safety from Iowa University, United States. And he's the director of quality and patient safety in King Abdulaziz Medical City, Riyadh, chairman of medication safety program. And Al-Kathiri is supervising and initiate a lot of and many of project initiative among the National Guard hospitals, organization related to the quality and patient safety. So let's welcome Dr. Al-Kathiri. Dr. Al-Kathiri.
Thank you, Dr. Shahar and Dr. Ali and Dr. Yasser for inviting me for this wonderful workshop with wonderful presenter and audience. Happy to present today about second victim. So we'll go through the presentation about what the second victim, what would they mean by resilience in stressful event, what our experience here in National Guard Hospital regarding the program. The presentation is, yeah. So I'll start with the story. طبعا this story is not confidential. It's available on NBC News. Anyone can see it. I'll talk about this. Kim Hayat, she is long-term critical care nurse in one of the biggest children's hospitals in USA. Her age it was 39. Had experience of 24 years in critical nurse. In September 2011, it was a horror day. When she was in ICU with one patient, she miscalculated a medication dose and gave an 8-month-old fragile baby an overdose of calcium chloride. And instead of give her 140 milligram, gave her 1.54 gram. The mistake contributed to the patient death. After that, Hayat was fired, her license was suspended, and she committed suicide, unfortunately, 6 months later. Hayat's dismissal and her death raise a large question about the impact of error on provider, the called second victim of medication mistake. This statement was phrased by our colleague, Dr. Albert Hu, a decade ago, maybe before 2011 and 2000, who's a professor of health policy and management in Johns Hopkins School. And he's a pioneer of this topic, and he has public workshop awareness around the world about second victim. So, who is the second victim? Let's start with the definition. The first victim, we are aware, the patient and family, patient who have suffered from the error or harm or sometimes die, and the family. The second victims, their healthcare provider involved in adverse event and as a result experience emotional distress. The third victim, there is controversial about who is the third victim. The IHI Institute for Health Improvement defined third victim as next patient harm as a result of emotional impact on the staff involved in the first event. Some sources define third victim as organization reputation, and fourth victim as next patient harm as a result of emotional impact on staff involved in the first event. So there's controversy about third victim. What the impact of second victim? I mean, when someone involved in adverse events, there's a lot of reaction coming. And either start from emotional feeling like anger, disbelief, embarrassment, frustration, grief, remorse, sadness, shame, and sometimes upgrade to psychological. It goes to depression and anxiety, and sometimes physical symptoms: exhaustion, fatigue, GI distress, increased heart rate, fluctuation in blood pressure, respiratory rate, muscle tension, and disturbed sleep. Sometimes professional, burnout, decreased job satisfaction, fear of disciplinary action or litigation, feeling of incompetency, lack of engagement, loss of confidence, self-doubt, questioning career choice. Also, healthcare worker can also be traumatized by patient-related events that don't necessarily involve patient's harm, medical error, or even their own direct involvement. These events include life and death events, bad outcome, conflicts with the patient and family, conflict within the healthcare team, other situations that challenge personal moral belief, such as resource, policy, or environmental constraints to their care. Why is it important to have intervention for those second victims? This diagram depicts vicious cycles of how lack of support of caregiver can impact unit operations through low morale and high turnover, quality of patients' cares, and satisfaction of patients and employee, and reputation of organization as a whole. For example, low morale, caregiver may feel miserable, came late to the work after adverse event, or maybe he wants to continue in the work area. This cycle highlights how stress can impact caregiver. If we don't have clear system to support them at the time, it will have significant impact on for feeling about work environment, about quality of care in the area, and about motivation to the work. And this can lead to the poor patient care and unsafe care environment when there is poor environmental work, lack of teamwork. This can have impact on patient care and safety of the care and environment. There is a lot of evidence to support that when caregiver there is low satisfaction, it will contribute to the low patient satisfaction and increase risk of harm to the patient. When there is low patient satisfaction, there is a threat to the organization reputation, and the patient will seek their care outside this organization. And this vicious cycle highlight the importance of having system for support those second victims after they experience this event. Also, the identification of physiological event of stressors is very important. It will help us to be aware about these symptoms, and those who not experience the system will be aware about these symptoms. In our normal daily life, our organization body react with any stressor through this resilience zone. In the normal range here, we have that line above and below, with this gray up above and down. Any mild stressors, our body will adapt and compensate through this resilience zone. When acute stressors like adverse event happen, our body will not compensate for this through the resilience zone, so it will experience stuck on from hyperarousal, from anxiety, panic, hyperreactivity, inability to relax, restlessness, through hypoarousal like depression, lack affect, lethargy, exhausted, chronic fatigue. So this red line go and above beyond this normal limit. So providing emotional and informational support from the organization found to be helpful in reducing the impact of adverse outcome on the second victim. So the first stress can knock caregiver out of their resilience zone, When caregivers are outside of the resilience zone, they are not personally or professionally able to maintain the highest level of optimal well-being or function. So we talk about that of intervention. So what is the intervention? So I believe John Hopkins is the lead in this program, in the second victim. They came the idea of peer support program. So who is the peer responder? He's a person who provides a confidential resource for employee to discuss their response to stressful clinical event. So what the RISE program is a support program for healthcare employees that they provide basic psychological first aid and emotional support. So why it's important, this program? To develop a safe environment where staff can access this program, reduce the impact of error on healthcare provider and the organization, provide multidisciplinary and peer-to-peer support in confidential and non-judgmental environment, and promote healthcare provider ability to continue thriving in their role. Also equip healthcare provider with coping and recovery strategies to promote well-being, and encourage healthcare providers to be involved in system change that will mitigate future error. So what the physiological first aid? So the person who is trained to stop bleeding at the scenes of an accident does not have the same skill or role as the person performing surgery. Both kinds of care are important, but they are not interchangeable. So likewise, resilience in stressful event peer responder who provides psychological or emotional first aid is not trained counselor, therapist, or psychologist, or psychotherapist, or physiatrist. You are a peer responder trained to meet with a fellow employee who have had experienced a stressful patient-related event. He or she needs someone to talk to right now, and peer responder is that person. So the purpose of this is to stabilize psychological and behavioral function and mitigate psychological distress, facilitate recovery, and promote access to additional resource. So it's a continuum of care. It's not only this, so you can go to the crisis intervention, counseling, and involve psychology and psychiatry at the care. So this is what analysis is important when you want to implement RISE program. What they're written about the literature, what the strengths of that? It's provide resource for staff. It's non-threatening, non-judgmental. It's timely support. It promotes resilience, retention, and satisfaction, and peer response relate to the experience. For the weakness, the resources sometimes need, and time and funding. For opportunity, it's increased awareness, safe cultures, better patient care, thriving in their role, and create new evidence. There is a threat, yes, scope creep. We are not replacing mental health work. We are complementary to them. And confidentiality and stigma of a new program. I will talk about our experience in National Guard. When you start this RISE program, as Dr. Shahar said, it's one of the standards of accreditation to support our staff who experience adverse event. So we're planning this program in July 2018. We review the literature, we see what happened in other organizations. In September 2018, we have a webinar with external experts from Johns Hopkins and Maryland Patient Safety Center. And we got expert opinion about what we can do here. So we did survey in October 2018 about the second victim for healthcare provider. And after that, we're recruiting the peer responder. So what we did, we send an invitation for all healthcare departments to ask for volunteer. We explain them to the program for volunteer for this job peer responder. In November 2018, we did workshop, expert visit from Johns Hopkins and Maryland Patient Safety Center. It was 2 days. 1 day for leadership for importance of this resilience and stressful event program. And another day for training for this peer responder, how to respond to call from caregiver who experienced the adverse event or involved adverse event. And we involve a lot of hospitals outside National Guard, Ministry of Health. We invite them, and we invite a lot of stakeholders also. January 2019, we did awareness activity through booths, posters, screensaver, panels. In any activity in the hospital, we are there most of the time. In April 2019, we launched the program. This is some question from the survey that we made. As a second victim, did they reach out to speak to someone at work regarding this incident? Around 60% said yes, 40% say no. Was this individual? We put multiple choice question. A colleague in the same profession, not sure, supervisors, a friend of the unit, a colleague in different person, an organization or structure, usually quality or well-being. Most of them, they put 32% a colleague in the same profession. Supervisor, 18%. Another question we put, if organization support is provided for employees in the situation that involves serious patient-related event, I would be willing to use it myself. So around 69% they agree on that, strongly agree 36, and 27 agree. Another question you put, if organization support is provided for employee that involve in serious event, whom you would access the support system? 73% they put as soon as the event happened, so the timing quickly after the event. This is some picture of the program that we made, this 2 days workshop with the executive leaders, and this the peer responder team training here, and this is our logo here for the program itself. So the RISE team members here in our National Guard have consisted of quality specialists, 4, clinical psychologists, 1, those who aim to coordinate and support the program and mitigate any event happen in the program and sustain the program through the continuum of care. The peer responder around 15 from physician, nurses, physiotherapist, pharmacist, social worker, patient relation. And those very important point to me is volunteer, all volunteer, didn't ask for, motivation like less working hour. They volunteer for this job. So the main responsibility, respond to call through a dedicated pager during working hour within 30 minutes. And we have a process for that, scheduling. Arrange for a meeting within next 48 hours if second victim need. Peer responder will provide psychological first aid to the second victim. A peer responder will conduct a debriefing with the team to discuss the second victim issue. And we used WhatsApp group and frequent meeting with all these quality specialists and clinical psychology. And also provide one-to-one or group support as required. And facilitate resource within the hospital that might be helpful. And very important thing, maintain confidentiality. So we have a consent for them to sign before starting the program, and he cannot ask for the name of second victim, where is his work, everything confidential. And he will fill the form after second victim call for physiological first aid. So this is the data that we have from April 2019. Total number of encounter 18. Profession of staff needed support, it was nursing 72%, physician 11%, respiratory therapist 6%, pharmacist 6%, and other 6%. This does not include group or repeated session. Someone will say this is a small number from April 2019 till now. Yes, it is small, but there is someone call. When we see the experience of John Hopkins, the number of calls the first year, it was around 20, 25. And I believe when the program presents more awareness for staff will increase the number. And this is, I think, the workshop awareness will increase, hopefully, the people who can call. So the support type of support that we have: phone 44%, face-to-face 40%, both 11%. Challenge and opportunity for improvement. Peer responders are volunteer who are busy with their bedside work. Misunderstanding of purpose of the program. We receive a lot of call not related to the adverse event, so we don't calculate it here. Fear of confidentiality breach. Valid preference for support. Also awareness about program and the culture barrier. طبعا the most important thing here, and I need to thank the peer responder who work with us. Most of them, when we met them last time, ask them if you want to quit, we'll bring another one. Most of them say no, we are happy about that. We need to continue with you in this program. And thank you.
Thank you, Dr. Al-Kathiri, for this outstanding presentation. I'm quite sure that many healthcare providers has experienced to be second victim one day or others. And at that time, there was no maybe RISE team to help them, to keep them in the, as Al-Kathiri mentioned, in the resilience zone, not crossing the upper or the lower limit. Dr. Ammar? Dr. Ammar? I'm not sure if Dr. Ammar with us, just to handle the question of the audience, and if you want to add anything to this topic.
While waiting for Dr. Ammar, Dr. Shahir, if you can, if I can make a comment here.
Yeah.
Please.
عمار أنا ولا واحد ثاني. السلام عليكم.
السلام ورحمة الله وبركاته. هلا دكتور عمر، كيف حالك؟ We haven't reached in I think your presentation, Dr. Ammar. He's looking for Dr. Ammar. He's his co-chair. But while we're waiting for Dr. Ammar, I wanted to make this comment. I personally have been a second victim, and I wished one day that I had this program to talk to and share my feelings. Particularly those who are working in high risk areas. Even a simple complication, that it's not an error.
Yeah.
You get those bad feelings when you go home, you failed to save patients, or you did your best and it didn't work out, or maybe you did your best and then it was not received by the patient or family or by the system in a good way, or even those bad moments of burnout or misunderstood, or even responding to SRS. A couple of days ago, I had a call from one of the colleagues in the field who actually treated patient with the clot-busting medications called TPA for a stroke. And this TPA is associated about 5 to 6% of hemorrhage in the brain, part of the business. So he treated one patient and basically he bled and the patient died. And he kept sending me on WhatsApp the images and say, please make sure that, did I do something wrong? Did I over-treat him? Did I under-treat him? Did something wrong? And twice and 3 times, and he kept actually calling me, and I just picked up the phone and talked to him, and we spent about 30 minutes assuring him that you've done your best, nothing went wrong, and he just wanted to talk. And I think this is very, very, very crucial program. Farah, thank you for starting this program. I know you're leading this, and I think this is the time where we take this to a higher level. I know Corona has affected the program and had interrupted some of the elements of the program, but I'm sure you and the leaders here in MNGHA areas and regions will take this. I think just culture, second victim program, and mental health program for us as healthcare providers are so crucial, and we should invest in them as a leadership. Thank you, Farah.
Thank you very much.
Thank you, Dr. Ali, for sharing your experience. And I think that we need to do awareness again for the employee regarding the second victims and other programs. We will have one or two more comment or question, please.
We have question here, Abu Ammar.
Please.
RISE program is a great program. If I want to join the team, would it be possible? And if yes, how? I believe here in Central Regions, I'm sorry to tell you, we have 15 wonderful volunteers. They don't want to quit. So if there's any consideration, if anyone he don't want, we can consider that. So if you can email me and I can help you on that. Another question, is there any qualification to be peer responder aside from volunteer? What does it take to be a part of the peer support? I believe the qualification that we get from Johns Hopkins and Maryland, one day they give certificate for the peer responder. But happy to help you. Our team here from the quality and the peer responder, they can help you on how to get qualification, even if you want to come here and get the training for that. The other question, the staff need to be more aware about RISE team and support. Yes, I agree with you. I believe awareness is very important. We'll look for a lot of channel to awareness. We طبعا any event happen in the clinical care, we will be there through the booth, through the banners, in any way طبعا. Thank you very much.
Thank you, Dr. Dr. Ammar just WhatsApped me up and they said he has a technical problem. So can we go to the third session, please?
Assalamu alaikum. Do you hear me?
Yeah.
Yes.
Assalamu alaikum wa rahmatullah. My name is Dr. Yusra Al-Atiq. I'm a clinical psychologist, section head for the newly established section. And I'm very happy to be part of this program or workshop. And thank you, Dr. Ali, for the invitation. I'm happy to co-share the session with my colleagues Abdulaziz Al-Ghamdi. He's a thoracic surgeon and in charge of operating room service. He's also the director of quality and patient safety, King Abdulaziz Hospital in Al-Hassa. I'm also happy to be actually sharing this session that talks on about the topic of mental health, because we believe there is we cannot talk about patient safety without talking about the mental health implication and aspect of the services. And I think Dr. Al-Khatami or Dr. Al-Kathiri just started this talk by introducing the RISE team as well. I cannot think of any person who can deliver this talk better than our next speaker, Dr. Omar Al-Mdaifer. He's a consultant psychiatrist and a family therapist, and he's the chairman of the Adult Mental Health Department. I've known Dr. Al-Mdaifer for so long through many different roles, and he's always been very passionate about the topic of mental health, whether in medical setting or social environmental aspects. I'm sure he will take us to a new dimension when talking about the mental health services through his talk today. So please join me in welcoming Dr. Omar Al-Mdaifer.
شكرا دكتورة، شكرا. السلام عليكم ورحمة الله وبركاته. أنا ظهر السبت، ما أدري من يجتمع ظهر السبت، بس الله يحييكم. كيف حالكم؟ عساكم بخير. وهذا جزء من الستريس مانجمنت انك تجي ظهر السبت. اول شيء شكرا للاخوان وشكرا للمنظمين وشكرا للدكتور علي والفريق المرافق له والزملاء في جده اللي كلموني، وانا طبيعتي شوي ما احفظ الاسماء فاعتذر منكم. في بس تعليق شوي على الكواليتي. انا وانا اسمع المحاضرات اليوم انا اعتقد الفكر الاسلامي از انترستنج في الموضوع هذا. في فكره اولى، اول شيء ان القدريه في الاسلام انك مسؤول عن نتيجه الفعل حتى لو ان الفعل قدر الله جل وعلا. هذه واحده مهمه في how to يعني counsel people. الثانية فكرة بذل الوسع، يعني الشريعة قامت على بذل الوسع، إذا بذلت الوسع يسقط عنك الحرج، يسقط عنك التكليف إن صح التعبير يعني. مثلا المثال اللي ذكروه الزملاء انه واحد يمتنع يسوي انتوبيشن للمريض والمريض مات، يعني اذا اخذتها بالفقه الاسلامي غالبه هو يتحمل المسؤوليه، لان الاصابه بكوفيد ليست حتميه، بينما يمكن الوفاه كانت حتميه. طبعا هي لها بعد فلسفي للتفكير، بس عاد بغيت اقول للاخوان في الكواليتي they could read into this a bit لانها it's very interesting topics، يعني من تطبب بغير علم وليتطبب بعلم يعني الى اخره، في قواعد حلوه. بالنسبه لموضوعنا اليوم، اول شيء شكرا للدعوه، والحقيقه انا قعدت افكر احنا ما ودنا نتكلم باستطراد حول المنتل هيلث وستريس مانجمنت فور هيلث كير وركرز. انا كان اي هاف ذا برزنتيشن مفرح ولا شلون؟ انا ما اشوف البرزنتيشن، تشوفونه على البرزنتيشن حقي؟
شفناه قبل شوي بس راح الحين.
رجع؟ خليني اشوفه، يمكن انا شلته بعد ترى.
اختار الديسكتوب واضغط عليه.
جاء الحين؟ مفرح معليش. فريان هو اللي معي. رجع الحين؟ اعتقد انه رجع.
دكتور من فضلك شير مرة ثانية البرزنتيشن.
I did already صح؟ رجع الآن؟
Not yet.
الأخ فريان هو المسؤول عنه أعتقد أنا.
معنا دكتور، موجود دكتور.
موجود؟
بس لسه ما نزل.
أنا من رأيي افتح البرزنتيشن على الديسكتوب وبعدين ادخل على مايكروسوفت سوي شير وحط الديسكتوب على طول.
حطيته يلا بسم الله. جت موجودة؟
أيوة جاي.
وخلاص ماني بلامس شيء الحين، أتوب. فأنا حقيقة I wanted to share you brief thoughts of my side. أول شيء commonly mentioned موضوع الستريس among healthcare workers is talked about a lot and many people talk about it. During the pandemic became more on the surface. صار أعتقد إنه أهم شوية وانتبهوا لها الناس. عموما يعني طبيعة الكلتشر الطبية اللي هي بيولوجيكال mental health يجي دائما second which is international، مش جديد عندنا احنا يعني. لكن اعتقد الانستيتيوت فيها الحس المنتل هيلث عالي. اعتقد المشروع اللي ذكروه الاخوان الدكتور مفرح حول السكند فيكتيم، اول ما بدات الازمه we had few initiatives in the CAO والميديكال سيرفيسز والكواليتي مانجمنت كلهم الحقيقه supported it very well which is really to be appreciated يعني. during the pandemic became on the surface. It is a normal phenomena. من خاف سلم، اللي ما يخاف ما يسلم. That's life. So you have to انك to be fearful انك تحمي نفسك، هذا طبيعي. فهذا الستريس الصحي اللي اذا زاد عن حده اصبح مش جيد. What's special about us as healthcare workers؟ أول شيء عندنا high level of stress comparatively، هذا documented research wise، واضح أن المنتل هيلث أن الهيلثكير workers غالبا عندهم higher stress level، وهذا related لأشياء كثيرة من ضمنها أنا أعلمها الطلاب، وأعتقد أنه أهم burden علينا في الحياة إننا مسؤولين عن الناس غصبا عنهم وغصبا عنا، which is an awkward position to be at. يعني أنت مسؤول عن المريض غصبا عنه وغصبا عنك. you cannot let go. واحد يبي ينتحر مثلا، انا في المنتل هيلث واحد يبي ينتحر انا مسؤول عنه. طيب هو اللي بينتحر ايش دخلني؟ لا انا مسؤول عنه. واحد جاء عنده بليدنج مو راضي يعالج، انت مسؤول عنه غصبا عنه. it's a very difficult position to be at، انك مسؤول عن الناس حتى لو غصبا عنهم وغصبا عنك. الثاني انه عندنا specific variables في الهيلث كير. الهيلث كير عندنا encountering so many people ما توهم receiving bad news، نتخذ قرارات قد تؤدي الوفاة أو عدم وفاة الناس. So it's quite difficult situation. عندنا shift work، عندنا الشغل ما ينتهي إذا تركت المستشفى بالسهولة هذه، عندنا continuous learning، عندنا التيم وورك is very important، والتيم وورك عادة يجيب معه الستريس حقه. ايضا احنا our stress is essential for patient safety. If we don't get worried about patient, they will not help them. في الاخير انا اقول انهم our people. احنا في الهيلث كير we have to take care of the healthcare worker. وكانت نقول ما لنا دخل فيهم، مو معقول. ولهذا leadership is always about taking care of your people who will take care of other people. And that's, I think, what we are trying to do in this institute, and we're successful, alhamdulillah, at it. During the pandemic, staff well-being became an issue, became also essential إننا نقدر كمجتمع to cope مع البانديميك. وهنا الآن صار المنتل هيلث well-being حق الستاف مهم مو بس له هو ولا المريض واحد. أنا أعتقد إنه became مهم for the society to cope at. لأنك لما تناظر الصور اللي كانت تجي من إيطاليا ولا من ووهان ولا من إسبانيا ولا من بعض الدول تشوف قديش الهيلث كير workers are stressed out. So it became an issue for us. فيه new factors. This is a new unprecedented experience for everybody. ما أحد منا جرب such an experience. وأنا أعتقد دكتور مهند أشار something like this. هي هذه event مستمرة. عادة الكرايسيس يصير and then you have to cope with الaftermath of a crisis. هنا لا، هنا الموضوع مستمر. الآن لنا 6 شهور ومستمر. We don't know how the thing going to evolve. So it's really different kind of stress. وطبيعته يكون له علاقة بالانترناشونال كله، بالعالم كله، له علاقة باللي يسافر واللي يجي، يدخل واحد المستشفى ما يدخل واحد المستشفى، ممكن زائر ينقل مرض المريض، ممكن طبيب يشوف أحد. يعني it's a very complicated scenario وكان ولا زال highly infectious virus. So it is very new thing for us. Also هنا المرة هذه كان عندنا personal safety more at risk. Usually as healthcare providers حنا at risk إلى حد ما مع اختلاف التخصصات وكذا، لكن المرة هذه لا، كان عندنا risk عالي على أنفسنا وما نقدر نقول ما لنا دخل. It's a very complicated feeling. You have to help people and at the same time you are exposing yourself to being infected. It's a very complicated matter. حتى لما حين تروح البيت وأنا سايكاتريست يعني حتى وكان عندنا تلفون خاص نخاطب فيها المرضى ومع ذلك الناس لما يشوفوني يقولون جاي من المستشفى ما نبغى نقرب منك. فكيف الانترنس كيف النيرسز. It's a very complicated. So we were more at risk as a group and كان الفيلينج أيضا complicated. كان عندنا أيضا feelings about the family safety. إنه الناس مو بس أنت خايف على نفسك، لا أنت خايف على عائلتك. وتعرفون فكرة إنه حطينا بعض الهيلث كير وركرز انستيتيوت والصحة والحرس وغيرهم حطوهم في فنادق. That's okay لكن that doesn't mean anything. في هيلث كير وركرز اضطروا ينعزلوا عن أهاليهم somewhere else. It is good. It's an appreciated movement. لكنها في الأخير it was a very difficult experience. Also an isolation experience. الايزوليشن اكسبيرينس سواء للناس اللي في الكورنتين او اللي ادمتد للمستشفى اعتقد انها كانت difficult. وبعدين انا قلتها في محاضره سابقه النيرسز became the family of the patient. اول في عندك فاميلي تزور وتشوف وتعاطف لا ما في فاميلي. الفاميلي هم الهيلث كير وركرز. اذكر انا وزملاء في الانفكشوس ديزيز لما كنا نناقش الهاي ستريس ليفل among some patients لانهم very isolated. يقول يا دكتور انا ما اعرف ما احكي مع احد حتى بالتلفون. يقول ابغى اشوف اوادم. واحد منهم يقول لي قلت النيرسز قال النيرسز ما ادري ايش يقول. he was looking at physicians to come in. الفيزيشنز ما يقدر يدخل ويطلع ويلبس PPE. It's a very complicated issue. والايزوليشن هذه حقت المرضى خلتهم يعني يعتمدون علينا اكثر وهذا جعل ستريس ليفل على الزملاء اللي في الفرونت لاين اعلى اعتقد. وهذا اكسبيرينس انا بسيطه مره. جبت الوالد كان مريض وعزلوه 24 ساعه وهو كان انكونشس ومره الان لو يحتاج المستشفى I will think many times اني اوديه ولا ما اوديه لان الايزوليشن اكسبيرينس is very difficult to people. فكيف لما تكون ايضا الزملاء اللي جاهم بوزيتيف تيست وراحوا ايزوليتد يعني it is an issue. بعدين صار عندنا نيو جريف اكسبيرينس. الناس عاده اذا مات لها احد تصير جنبه تعزي. المره هذه الواحد يموت واهله بعيدين عنه. الهيلث كير وركرز هم اللي في الوجه. العزاء ما في. طقوس الدفانه المعتاده ما في. يعني it's a very complicated grief المره هذه احنا عشنا معه. وانا اعتقد انه حيطلع معنا consequences مش انها صعبه لكن we have to deal with it as time goes by. ايضا it's a very ambiguous situation. اول ما بدا الحدث كانوا يقولون تذكرون يقولون الكمامه ليس لها فائده. اليوم الكمامه اجباريه. هذا فقط simple example انه it is a very vague situation with changing guidelines وانت ما تعرف ايش تسوي how to catch up وفي رومرز وفي كذا ويطلع من هنا ويطلع من هنا. So it becomes very complicated issue الحقيقه. وعندنا موضوع كبير وخطير اعتقد انه شيء اللي يجي له الالتهاب، وهذه مهمه في الكواليتي اعتقد وفي السبورتنج ستاف. الناس اللي جاهم انفكشن felt انهم هم السبب، هو قصر، هو didn't take the precautions, he did not put properly the isolation strategy, didn't follow the guidelines. يعني it becomes a blame and a shaming issue. It is difficult. هذه ترى الهيلث كير وركرز وللريجولار individuals صار في عندنا shaming, blaming، لأن الناس تعتقد أن الانفكشن is avoidable، ومن ثم if you get it it's your responsibility. And if you are a health care workers أشد وأشد. فit became أعتقد هذه is an issue. وعطتنا complication. The last thing في الفاكتورز اللي جت هنا بقوة هي trust and confidence were challenged. When you trust confidence، when you challenge confidence وثقتك في نفسك وفي اللي حواليك، هذا very highly stressful level. يعني لما if we have a team player who is not confident in the rest of the people, he cannot do a good job. So we had يعني difficulty in confiding in ourselves and in the team and in the institute. وهذا تراوح بين مستشفى ومستشفى، بين institute وinstitute، حتى في الحرس اعتقد انه تراوح بين region وregion. وهذا كان very important to pull things together, and we tried and everybody tried, and I think we had a good journey. يعني احيانا text message من ال CEO ولا من الوزير made a major difference. Text message from us, the healthcare worker, that we are available to help you. All the people did not seek a lot of help, but they felt we're close by. الناس انها تعرف اللي سواه الزملاء what happened in the briefing weekly, and we have enough supply of PPE مثلا is very useful. كان فالconfidence was challenged, and that makes it very stressful. في COVID the confidence was challenged significantly. So what we did, and we hope to continue in the future، احنا في healthcare workers، I'm presenting this as a model to that we can continue doing, because in the past healthcare workers' mental well-being was not although a priority. We had a lot of initiatives. We have staff well-being program, we have stress management program. الزملاء في quality have their protocol taking care of the caretakers, and we have to continue that. What we did, and now we started to go on phone and virtual clinics, so we did not let our patients or staff down. We had COVID response team immediately assigned, so we call every patient, and eventually we started staff well-being hotline, which was important. There are no many calls, yes, but it is a window for intervention. People who will need it, they will come. We had employee wellness clinic to continue, and we expanded. We have online support groups, which worked quite well. We had a well-being survey with our colleagues in the quality, and it gave us a good indicator. And we took the people who we think they have higher level of stress, and we called them separately for different sessions. We had a family support also program, so the healthcare staff families could be supported, and we have an awareness line. These are some of the data we had. The screened patients. This was early on statistics. Also, we have the employee wellness clinic we had added a second slot, and it is continuous. It's not only COVID related. It started before, so it will continue, but it became more appreciated by everybody. Extremely nursing during the pandemic. We have a hotline. Also, we have some calls, and we are still having it. There was some technical issues and not a very good marketing, but eventually I think it will be an important window again. We have a BeWell group support for frontliners. So with the quality department in the corporate level, we try to target the frontliners, people who work in COVID wards, people who are in the ER, people who might be exposed, and we targeted them with BeWell group support. Now, again, the attendance does not mean a lot because of multiple factors. But what we have to do is to make the service available. Then we pick the people and we give them other options. Also, we have a specific program for head nurses, so they can support their staff to reach for help. And we have, this is very important. Now we have a drop-in staff support room online. You can just scan the code, and then you go. And every Sunday from 12 to 1 p.m., Arabic and English, so people can come in as if it is a real room, and people can come in it and get some support or get referred to services or be seen in person, or they attend a seminar based on the recommendation or whatever. So the idea is to have healthcare providers provided with opportunities for intervention. And we are going to propose other initiatives next week with a meeting with the CEO. But we would like to focus on to that the mental well-being of healthcare providers is at risk, and we can manage it. It's not something you cannot manage it. So there is a lot of doable things can be done, and that will minimize a lot of issues which some of the directors are facing in their places. And we cannot let go of that. If you look at patient safety, then staff safety and staff well-being will make them practice safer. As you know, people who make mistakes, either intentionally or unintentionally, which is I don't think many people do it intentionally. It's very rare to do that. That's a crime. People who make mistakes usually have a different status level of their mental well-being. For multiple reasons, could be transient, could be long-term, could be related to the job stress, could be related to personal stress, but stress is a manageable phenomena, and we can do a lot about it, either through training, awareness, treatment, by medication or by therapy, and we have a lot of approaches to do that. I think that's my last slide. Thank you for listening, and I hope it was a fruitful presentation. Thank you.
Thank you, Dr. Umar. Well appreciated. It is an excellent lecture, and the way you mentioned the proactive measures and programs from the institute was actually helping a lot. You mentioned that those messages from the minister or from the CEO made a bit of difference for each one of us as a healthcare worker. It seems that such lecture is very interesting for the audience, and I can see a lot of questions coming on. And I will start with this question: like, how can we proactively assess those at risk?
We can. First thing, we have to down-tune the blaming attitude and to open up more of a caring attitude. We are in healthcare, so we care for people, and our staff are human beings, and they are. We have to always to be attuned to their care and their need. I think what happens if people change, that's important. If a unit had issues after an incident, which we had it, let's say, once we had an abusive VIP patient, and we had to do a group collective work to calm the nurses then. We had it in the NICU when there was a series, this was a few years ago, when we had a series of events in the NICU and people became very stressed. Then we went there and we did preventive work. So if there is a change, whether an individual or in a culture, then you have to assess what's happening. And always think of it as a solvable, not intentional issue. And that helps you to find it well. And also we have to look at historical, what's happening. Always things does not come out from nothing. And as I said, we have always to think that people try their best, and if they're not, then they have some issues they need help with. And just as I think Dr. Mfarrah said, if a colleague of you asks you, are you doing fine? Is that okay? And that women are much better doing it, by the way, than men. And men physicians are very bad at that. So when you count on somebody's shoulder and you tap on it, people feel very good about it. It's not very. We are still humans, and everything works for him and works for us.
Well, beautifully outlined, Dr. Umar. Yusra?
ما اسمع.
أقول beautifully outlined. يعطيك العافية. يسرى.
Thank you very much, Dr. Umar. I think there is a question here from the audience. How can leaders differentiate between pushing their employee to be productive and not putting them into continuous pressure? So how can they make that balance or differentiate between,
yeah, that's a difficult balance. That's a difficult balance. So also, and it's more difficult if expectations are different, and that's when system issues becomes important. If the expectations are unified, and probably if we go proactive for quality, then everything is measured. Then the difference between pushing the limit or being productive becomes clear. But if the people are not aware about what is expected from them, then it becomes an issue. But as any society, in a group of people, you will run into difficult people and non-difficult people. That your job as a leader is to take care of difficult people. If you are a good leader, then you have to do your best. If you can't, that means you are challenged with the situation, maybe relevant to you, maybe relevant to them, maybe relevant to the institute, and then we can find another solution. But I think the balance here is very fine and difficult to find, extremely, that when the outcome is not measured nor quantified. So let's say, I'll give an example for quality. Quality is about, now we're talking about SORS, which is fine, but also how about patients who are not doing well? If you have a physician, his patients are not doing well, and a physician, his patients are doing well, then what's the difference between them? You can say those are difficult patients, yes, but what you can lead? And so the accountability here, it's pushed the limit to the positivity, but at some point you will hit the wall with some people, and that's life.
Dr. Umar, يعطيك العافية, Dr. Umar. So now, as you mentioned, the pandemic is definitely new experience for our healthcare worker. We've been continuously working for months. Nobody can get vacation and all that. So what are we expecting in, let's say, that in a year from now? Is there something going to happen for the mental health of all these healthcare workers who were working during this pandemic?
I think it's related to two things. One thing is the coping skills of people. How are we coping as healthcare providers? Are we doing well or not? There are personal factors. There are personal, and there are institute factors. And that's, we have to do more work on the few coming months. The second thing is there will be some victims. There will be no doubt about it. There will be some people who will have significant anxiety. Some people will have significant interpersonal issues. Some people will have, will resign. But I would say those are the minority. The good thing about healthcare workers, to be able to cope better with this, which we have already, is usually a healthcare worker have a mission. You have a meaning. When you are doing your work, you have a meaning for that. You are not somebody who does not have a meaning in helping people. And that's usually the case. And meaning makes you cope much better. Meaning makes you cope much better. في آية في القرآن جميلة دائما أذكرها. الله قال إن تكونوا تألمون فإنهم يألمون كما تألمون. فالألم متساوي. لكن قال وترجون من الله ما لا يرجون. فالmeaning is what makes people cope, and I think that's good in the healthcare world. So we have, and what also this crisis gave us, we are more accredited by people. We are more appreciated by people. We are more looked at people, which is, I think, is a positive thing. So there will be some victims. We have to do more of stress management strategies and to talk about it. We have to do some sort of positive environment changes, but at the same time, subgroup will need intensive care and intensive help.
May I add, Dr. Umar, just when you talk about the meaning of the experience that individual actually go through, it reminds me of one of your talk to this during the stress management program, is looking at the growth from that experience. And it's not always the traumatic experience they go through that it's an ultimate direction to suffering. Sometimes people actually have a growth during that experience. Could you tell us a little bit about this, please?
It has been documented that societies who go through crisis, they go through phase of coping, and some of them will develop post-traumatic stress disorder, some of them will fall apart, but then eventually people normalize, and a good subgroup of people will grow out of that. So let's say, and you can look at this disaster growth, post-disaster growth. You can look at this at research. Let's say 9/11 in New York resulted in the community became less aggressive. They say about it, they talk about it. I think it's also measured. There was an earthquake, I think, in Georgia or Louisiana, and after that, people became more caring for each other, more sharing, and I think we had seen some of these things in the crisis. The foundation of the Saudi culture is of interconnectedness. So we are interdependent, interconnected. We are not very individualistic. So you didn't have that rush where people take resources and leave the others. We didn't have it. That's an issue. And that's, I think, religiously based, culturally based, and that's something we have to appreciate. So growth here in the healthcare sector, I think, would be that we are more appreciated, we are more confident in ourselves. I think, alhamdulillah, there was no major breakthrough in this crisis, although we are all up on our toes, but we did a good job. We did a good job, and that makes us believe more. And I think even at a national level, people will believe more in the healthcare sector after this crisis. And for me, personally, during this crisis, there was an open communication, medical services, quality, infectious disease. For us as a healthcare, as a mental health professionals, usually it's not always that smooth, but we were called to work, we were provided with our resources, and we felt more appreciated. So I think that's applicable to all our colleagues.
So, Dr. Umar, your lecture and yourself actually made the attendees, along with the moderators, very engaged with the topic. We're very happy to have it. And I guess Dr. Ali Al-Khatami has a comment and question for you. Dr. Ali?
Dr. Muhammad, thank you so much. That's a great presentation as usual. I usually enjoy your talk and your presentations. Amazing. Now, one of the things that caught my attention when you were talking is caring organization. So we always hear about patient-centered healthcare system, but we don't usually hear healthcare worker-centered organizations. So caring organization for its employees is very, very crucial for patient safety, because if the employees do not have a good well-being, فقد الشيء لا يعطيه. Right. So we have done we have really when we appreciate your contribution, your leadership, yourself, Dr. Yusra, and your department has contributed massively during the epidemic, and you're still working on that. We have multiple programs, parallel in different departments, targeting different groups. Do you think lumping all these initiatives, putting these projects under one strategic goal at the entire system would be a better approach than, these pieces here and there?
I agree with that, and I have noticed that everybody has initiatives, and that makes it in a smaller scale, makes the resources competed for, also makes it not very strategic. It's not difficult to work on that. I think I don't think it's difficult at all. We are blessed with a good organization. We're I think the best, if not the second. I mean, some people think Kosovo is second, but I think we're the best organization in the country from the healthcare, providing size and quality and variety. And people always think about taking care of staff is about salaries. It's not always about salaries. It's much simpler than that. I mean, salaries are important, but they're not. And even, a survey done by BCG, I think, Ali, you have attended that presentation with me. BCG, or one of the consulting firms, they did a survey among people, and they felt they want to be in a reputable, respected organization prior to having a better salary. And I think that's we can build on it. We can have a simple strategic, and also the digital platforms now makes accessibility very easy. So you can send a random message to people, You can do a lot of simple things which before it was difficult. You know, reaching out to people is very costly. Now reaching out is very simple. It's very simple, and we can phase it out. We can do it in different ways. It's like when you send a text to your son saying "How are you?" rather than "Where are you?" It's the same one, but it's different. It's different. So I think we should do that. It should not be difficult, because it's only just putting things together and strategizing them.
So, Dr. Umar, يعني, since like all these ideas that mentioned by Dr. Ali, and also the one that you mentioned during your presentation, who should, like from your experience or from your knowledge, who should think that there should be the governors for the mental health for healthcare worker in the coming future? Like, is it like should be some department, or it should be like the leadership? What do you think?
And my proposal to the Institute long time ago is mental health to become more of a corporate identity, because at this point in time you have different resources, different level of resources. So if you go to Riyadh, you have different levels of resources than Medina, then different level than Dammam or Al-Ahsa or Jeddah. It's totally different. And maybe in Riyadh we're doing much better because we are equipped to do that, not because we're better than other people. So I think making mental health a corporate would be an idea. Also, or we can have some sort of something linked to staff well-being linked to a corporate department, not to a regional department. And that's where resources can be created and mobilized and I would say governed.
Especially
in a reasonable way.
Especially nowadays with technology, things would be way easier. Like having these meeting and having all these one-to-one coaching and all that should be easier, especially if it is taken from corporate level. Agree to that. Yusra?
Thank you very much, all. I don't think we have any more question. All the comments is actually thanking you, Dr. Mudefer, for the talk and the presentation, and I think it's wonderful. Being part actually of that initiative and working with the staff. Maybe this question for you, Dr. Umar, but also for anyone who can actually hear us. During this initiative, the hotline and the staff support group, and the last initiative, which is the staff support room, which is open every Sunday, despite all effort to announce for it, we believe that is not utilized as we hoped. And if people are not needing these services, that would be fine. But sometimes we always hear things like, we didn't hear about this activity, we don't know that we have these services. So I'm just putting this question for everyone. How do you think we can further approach and reach out for everyone who actually need these services and that support?
Is that for me, the question?
For you and anyone can actually, but maybe you start, Dr. Umar.
I agree. It's a challenge, but I think our job is to create the opportunity for people, and we can have also an advanced strategy later on. There is a strategy done in corporates where they have a list for employees who have some difficulties, which is a very confidential list. And then they will launch some sort of courses, and they will invite 50 people, 10 of them will be from this list. And they free up their time and do it. So there are some strategies where we can recruit more needy people, but it is a culture of openness and creating opportunities, and people come in business. We talk about two models, a model that you create business, and then the market will be created later on, which is also always happens, or the opposite. And I think we're doing here both ways. We're creating a market and also tuning into the needs. So we can do that both.
So, Dr. Umar, though the time is limited now, but I think this is an important question by one of the attendee, and he's saying that some of the healthcare workers are denying their mental stress. They are denying that, and they're trying to show, but actually they are affected by the pandemic. So his question basically is asking, how can we make them come forward and talk about it? What would you think about that?
Yeah. Stigma is always there. So people doesn't want to be told, go to a psychiatrist. That means they are crazy. It's simple. But what you can do is their leader, their manager, can tune into that they're not doing well. They need to talk to them. We might need somebody to coach you on how to cope with certain things. But if you say it's like physicians. When physicians tell a patient when he comes with somatic symptoms, so they tell him you have nothing, we'll send you to a psychiatrist. He will say no, because he has something and he feels real pain. But if they told him, well, you don't have major issues, which is great, but at times people will need, who have stress, they will have some somatic symptoms, and then we'll see, let's check your stress level, or to find a way to help you with that. So I think how it is done is important, but some people will need some sort of force, and that's doable. So your evaluation going to be impacted unless you go to see the wellness clinic. What we did in Riyadh is we have in the employee health clinic, we have a wellness clinic. So they're not booked with a psychiatrist or mental health, it doesn't show up anywhere else. And they go there, and that will be their entrance to the service. So we can, but if there is somebody who needs help, if you tap into him, he will accept that. But if you blame him, he will not accept that. That's I think, very, very, very crucial issue, which is difficult, not easy, to be honest.
So not blaming, huh? So not blaming culture. We'll try to do that, inshallah. We'll try to do that. Yusra, anything from your side?
I think we're there is no more question. And just for me, I want to thank Dr. Mudafer again for this wonderful lecture, and for you, Dr. Abdulaziz and Dr. Ali, and coming up with this workshop. I think during this time specifically was a very great opportunity for everyone. Thank you.
Thank you, Dr. Omar.
Thank you all. Thank you.
The floor is yours, Dr. Ali. Tafadhal.
Great. Are we coming into the end?
Unfortunately, yes.
Truly great presentations, wonderful speakers, very enriching discussions. I have learned a lot from all of you. Truly great honor to have you. Thank you for the audience who actually stayed with us, although it's a Saturday afternoon and typically it's a family time. It has been a wonderful experience. At least I have in my mind 3 critical issues that we need to reflect on as a quality and patient safety, as well as the organization: how to promote safe and just culture, how to further push forward for the second victim program, and how to have a strategic plan for the mental health across the organization. I think we have a lot of business to do when we go back to work Sunday. Thank you for everyone. Thank you, the audience, for your contributions and for your comments. We will go through all the feedbacks and comments. Enjoy the rest of the day and have a great weekend. في أمان الله.
في أمان الله جميعا.
شكرا جزيلا.
يعطيكم العافية جميعا. شكرا.
شكرا جزيلا ويعطيكم العافية.
يعطيكم العافية، ما قصرتم.